Good evening, everybody. Welcome to the ESU online webinar on behalf of ULIS and EWPU on pediatric urolithiasis. My name is Emanuele Montanari, and I would like just to introduce just the webinar. Saying that the child with a stone is on the top of a non-index kidney stone patients, really, as you'll read in the AUA guidelines. And the urolithiasis, we know, is a symptom, especially in pediatric patients, in which we have the problem of the diagnosis, that it's not always so simple. The metabolic evaluation, that is a part very important of the process, and the etiological evaluation that is mostly important in the evaluation of a patient who can relapse and relapse and relapse in a very long life, we hope. Of course, multidisciplinarity in this field is of extreme importance, and pediatricians should work with urologists and radiologists in a strictly way, really, to find the best solution for the problem. And two concepts in my mind that are very important, and the importance of this concept is that the child is not a little adult, and we have to find a solution for the child that are different from the solution we have in the adult. And when you have a stone in the child and you have to treat it, you don't treat only the patient, but you have to treat the family, really, the father, the mother, the grandmother, the aunt. Everyone asks you something about the best treatment you can afford. Our goals in the child with the stone are in this slide can be seen that is the best and immediate stone-free rate achievable. The minimal invasivity, we have to propose a treatment with minimal invasivity, really, and the lowest complication rate achievable should be assured for the patient, and less procedure and anesthesia as possible, and safe radioprotection protocols that perhaps even of the temperature on during the surgery, and a short hospital stay. And as the Queen says, we want it all, we want it now, and hopefully and possibly without any complication. This is a short, really, overview of what you will try to achieve from this fantastic webinar. And to do that, you will have the possibility to listen to very, very good experts in the field. And I leave to my friends, Dr. Spinoit from Ghent, the conduction of the next part of the webinar. Thank you very much.
Thank you very much, Emanuele. It's really a pleasure to welcome the host today to this very first Pediatric Stones meeting, conjoint meeting from the ULIS and the EWPU. And to start this talk, please, I would like to invite Professor Sarica. Professor Sarica is from Turkey. He's the chairman of the Urolithiasis Association of the EAU. And he's going to talk to us today about pediatric stone wave lithotripsy. So please, would you share your slides and start the talk? Thank you very much.
Thank you very much, my dear friend. First of all, on behalf of ULIS board and its working members and its staff, for organizing friends from European Pediatric Working Group to join us and to share their experiences for the success of this webinar. Paediatric urolithiasis is a multifactorial disease with high recurrence and morbidity. We know it very well because the etiology is totally different from the adults. When we evaluate, here you see metabolic problems, counts up to 50% of the cases, which is really responsible for the higher recurrence rates. It's a problem for us for the repeated procedures to be done in a particular subset of the kids. It's a management dilemma because there are some certain concerns around us. Possible adverse effects of the treatment on the growing kidney, significant recurrence rates, as I told, commonly underlying metabolic disorders requiring repeated procedures, and also we need a cooperation, close cooperation among the involved departments as well as parents. Parents may be the co-patients here in this subset of patients to be treated. Aims of the treatment in this population is complete stone clearance with minimal or no complications in terms of being invasiveness, eradication of the urinary infection, and correction of any underlying metabolic or anatomical abnormalities are very important. To realize our objectives, we have to combine the most effective and least minimal invasive surgical treatment available, and also we need an appropriate prophylactic regimen, particularly for the kids having a severe metabolic abnormalities. What are the options, minimal or non-invasive management options to treat the stones in pediatric population? Shock wave lithotripsy, ureteroscopy, and PCNL. My topic is shock wave lithotripsy, and here you see it has been introduced in beginning of 80s, first experience in 1986, but this procedure has not been approved by FDA so far, and it's really highly successful in children, as I mentioned later on. Shock wave lithotripsy has some certain advantages in kids because we know that children pass stone fragments well and do not require routine standing when compared with adults. IV sedation may allow treatment in select older children. Newer generation lithotripters with smaller focal zones allow less painful shock wave lithotripsy in this population. And also we know that better stone fragmentation and higher stone-free rates could be anticipated due to factors. Here are the factors, because we know that stone formation has a shorter period in kids. Lower resistance of the stones to the high energy shock waves is a reality. During the treatment, lower absorption of high energy shock waves by child's tissues is also another advantage for us. Child's ureter is shorter and more compliant than adults, allowing higher rates of spontaneous passage of the fragments, and also children are mobilized earlier than the adults. And stone size, like in adults, is a major factor for the success rates. And here you see, if the stone size is less than 1 centimeter, more than 95% high stone-free rates could be anticipated. But when the stone size goes up, as like in adults, the stone-free rate will come down. Also, at very young ages of the children, we can perform this procedure. Here you see, coming from the literature, even in very younger ages, high energy shock waves could be applied to treat the stones in a, let's say, very careful manner. It is possible. How about the success rates? It's a nice study summarizing the success rates in this population, and the overall success rate may go up to 100% depending on the stone size. Monotherapy in large stones is successful also in a major percentage of the cases. In second calculi, lower pole calculi, even in lower birth infants, stone-free rates are really high and acceptable. When compared with the adults, this is a publication coming from our group concerning the lower pole stones. We may easily say that shock wave lithotripsy is really effective also in lower pole stones in kids. Here you see, when we compare lower pole stones with adults and children together, and more than 67% of the cases after first session were stone-free in kids when compared to 28% in adults. Also, in another study here, you see, comparing all calyceal positions to treat the stones in kids, lower pole stones also are really very responsive in terms of disintegration, and also spontaneous passage rates really are high. How about again, this study is focusing on the stones of different locations in kids, and when we evaluate the lower pole stones, again, when comparing with the renal pelvic stones and the other calyceal stones, 72% of the kids were stone-free after shock lithotripsy. Another reality or advantage is obesity is not a disadvantage for shock lithotripsy in kids. Again, a study coming from our group, and here you see in the end of this study, when we compare the obese and non-obese cases, we were able to show that in obese children also, higher stone-free rates could be anticipated. Does child's age affect the interval of stone-free status after shock lithotripsy? Again, one of our study published in the literature, and when we compare older and younger children, again, we were able to show that in younger children, shock lithotripsy is even more effective than older children. Stone size is very important for us, like in adult, and as I told, stone sizing less than 1 centimeter, we will have around 90%, 93% stone-free rates, but also for stones, moderate size stones, again, acceptable stone-free rates could be anticipated. In concerning the anesthesia, again, in relatively older children, in children older than 10 years, ketamine midazolam combination could be used as an effective and safe choice, coming from data coming from one of our studies. Also, if we have an appropriate dose adjustment in a monitorized manner, we will be very successful with this approach. Huge study is coming from Pakistan. Again, here you see shock lithotripsy provides excellent stone-free rates in stones sizing less than 15 millimeter. This is a summary coming from Professor Slay, published in European Urology Focus, and here in the end, he stated that it remains an important treatment option for kidneys sizing less than 2 centimeters in kids. How about the guidelines? We talked something coming from the published data, but guidelines also giving us the reality. Shock lithotripsy is very effective in kids for stones in pelvic position less than 1 centimeter, for moderate sized stones, and also in lower pole stones and for ureteric stones. It is really effective and successful. Complications is important, and a huge series in a huge number of cases. Here you see most of the complications are minor in case, and most of them are also related with the stone size. If we choose the stone size well, then we will have really very limited complications. Here you see 13 trials, a huge number of cases, and 12% of complications have been observed. A majority of minor nature. We need to have some say about the effect of the high energy renal growth is very important. A nice study coming from years and years ago when I was studying in Salzburg in 1991, but I had the chance to use HM3 in kids, and even by using HM3 in this specific population, here you see how to treat it, and here you see data coming from the literature to show us that shock lithotripsy is effective and on the function and morphology of the kidney. We maximize the efficacy by using sonography, particularly in this population. Anesthesia is an advantage in immobilization of the patients during the procedure. The number of and energy of high energy shock patient, and also a relatively low power are applied in this specific population. To conclude, I may say that technological advance in stone management techniques have had a significant effect and successful outcome. However, unlike in adult cases, minimal or non-invasive techniques should be used to treat calculi in children because of the greater probability of stone recurrence due to the commonly associated delicate tissues and possible long-term complications. Proper and detailed planning of the surgical procedure is of utmost importance in pediatric cases. currently treatment of choice for the vast ones. However, there are certain different indications of endoscopic intervention in this specific population, depending on the stones as well as patient-related factors. And my dear friends, we'll talk about these subjects. Thank you so much for your kind attention.
To introduce the next speaker. The next speaker is Professor Bhaskar Somani. Welcome. You're working in Southampton, and you've been recently awarded the prestigious award of the BAUS. Congratulations for that. So please, would you tell us more on ureterorhinoscopies in children, please?
Thank you very much, Anne-Françoise. This is my pleasure to be here. Again, it is a great pleasure to do this talk on pediatric ureteroscopy as an EZU course. My name is Professor Somani, and I'm going to take you through a brief journey of pediatric ureteroscopy. These are my relevant conflict of interests. So let's see what the EAU guidelines on pediatric stone disease actually say. In children, the indications are similar to adults for all treatments. However, ureteral stones less than 1 centimeter, shockwave is the treatment with ureteroscopy as an alternative. Similarly, in renal stones less than 2 centimeters, shockwave is the treatment with ureteroscopy as an alternative. But for larger stones, PCNL is the treatment of choice. And you must offer metabolic evaluation and recurrence prevention with respect to the stone type. What about evidence for semi-rigid ureteroscopy? Stone-free rates are fairly good, 80 to 98%. Retreatment rates quite low. Complication rates variable between 2 and 23%. And routine stenting is not needed, but it can facilitate ureteroscopy in terms of stone-free rate and complication rates. What is the evidence for flexible ureteroscopy? Again, stone-free rates between 76 and 100%, retreatment rates up to 19%, complications up to 28%, but they're especially useful for lower pole stones with unfavorable anatomy, and predisposing factors for failure are young age, cystine stones or large stones, and if they're not tree-stented. And compared to PCNL, they do offer a slightly lower stone-free rate, but with less radiation, complications, and hospital stay. So worldwide, we know the trend for ureteroscopy is actually increasing, and for lithotripsy, it is coming down. And that is down to a lot of factors, technological improvements, and the trends for intervention for pediatric stone disease, if you look, ureteroscopy and minimally invasive PCNL is also quite rising rapidly. So we have looked at our own series of ureteroscopy for 81 patients who had 102 procedures, 1.3 procedure per patient, with a mean age of 9 years and a wide range between 1 and 16 years, cumulative stone size of 9 millimeter and ranged up to 3 centimeter, stone location, 3/4 of them in the kidney, of which most in the lower pole, multiple stones in 1/4 of them. The pre-op stents up to 1/3, post-op stent lower than what you'd expect in adults, 60%, an access sheath used in 1 in 5 patients. The initial and final stone-free rate almost 99%, and the complication rates, and here's the beauty of modern day ureteroscopy, only 3%, readmission rate less than 1%. And actually, the complications were related to urinary infection with 1 sepsis and 2 urinary infections. So modern day ureteroscopy for pediatric patients is actually quite safe. How do we do it? We have a twin surgeon model with pediatric and adult urologists. We jointly discuss them at the Stone MDT. They are seen and managed by the pediatric urologist. We operate on them jointly. Excellent outcomes are achieved. And actually, this model is now adopted in several UK centers. Having said that, the adult endourologist with enough experience, the learning curve is quite short. And actually, this paper shows that the comparison of 15 adult and pediatric patients with a surgeon who had more than 500 ureteroscopy with no previous pediatric experience, and the stone-free rate are comparable. And they say that expert endourologists can achieve good outcomes in pediatric population when compared to adults. I must add, though, it is not just about procedures, it's also managing before and after, and hence teaming with a pediatric, a group or a pediatric urologist or pediatrician is a good idea. Now, not all pediatric patients are same. You can have a very young toddler to a teenager. In this paper, we looked at the complication and failure rates. And as you can see, the failure rates are almost 4 times higher in patients under 6 years of age and complication rates also at least 3 or 4 times higher in the younger than 6-year age. So you must be very careful in the under 6 or the very young age patients who might need a higher rates of preoperative stenting, and you must be watchful of the complications. What about access sheath use? It's always a slightly controversial topic in pediatrics. We looked at a small series of patients with a mean age of 12 years, but range from 2 to 16 years. Large stones, we use the smallest possible access sheet. So I use a 9.5, 11.5 French access sheet. And when we look at the preoperative stent rates, 8 were pre-stented, extremely good stone-free rates, and no complications over a period of 26 months. So actually, access sheet use in pediatric patients in selected cases has a good outcome with no complications. Moving on, what about the difference between ureteroscopy and mini PCNL? This was from 2 different specialist centers, one on ureteroscopy, which was our center, and one on mini PCNL, with comparable patients. Although the PCNL group had slightly larger stones, ureteroscopy group had more multiple stones. Postoperative stent rates were higher in ureteroscopy, 44% as opposed to 30% in mini PCNL group. But the overall stone-free rate was very similar, 100% versus 97.5%. More patients were discharged the same day or the very next day in ureteroscopy, and the complication rates were similar. So actually, it depends on the center and your experience, and you can achieve good outcomes with both procedures. But ureteroscopy remains a procedure of choice for these patients. What about low pole stones? This is a paper we published in adults, but we have now recently looked at the paper in pediatric patients from 2 large European tertiary centers. And this has 57 patients who underwent 68 procedures. And when we look at the initial and final stone-free rate, the final stone-free rate was above 98%, with 1.2 procedures per patient with 4 minor complications. So actually, even for lower pole stones, possibly ureteroscopy is edging towards lithotripsy in terms of the gold standard. What about the procedural? How do we do it? I always do a rigid cystoscopy and place a safety wire first, then do a semi-rigid ureteroscopy, and I use a needle scope, 4.2 scope for this, and then place a working wire, and then an access sheet if necessary, and then a flexible ureteroscopy navigation with or without access sheet. And this is how we train, and this is what I recommend everyone should be doing. Going forward, total fluorosis is an option, and the group from Spain with Emiliani and Bijons have looked at it, and they have gone through who actually needs fluoroscopy. They always have fluoroscopy as a backup, but they have shown that in most cases, you can do it with minimal fluoroscopy. What about pediatric outcomes in medium volume centers? We looked at a review of literature. Medium volume center were defined as up to 50 cases reported, high volume over 50 cases. And actually, ureteroscopy was found to be safe and effective in both these groups. So medium volume centers can achieve an equally high stone-free rate and safety profile as high volume centers. What about the role of high-powered lasers? This was a pilot study. We looked at the role of dusting and pop dusting for pediatric stones. This is a 2-stage procedure that first starts with dusting using low power, high frequency and in contact mode, and then followed by pop dusting in the non-contact mode. And actually, the stone-free rate in this group was very good with no complications. So dusting and pop dusting actually are actually going to be probably new gold standard for especially large stones. Initially, when we started doing, we thought we can't do it, but actually you can. And how do I do it? Urine culture, up-to-date ultrasound imaging preoperatively, antibiotic prophylaxis at the time, cystoscopy, safety wire insertion, semi-rigid ureteroscopy over a working guide wire, access sheet use only if needed and possible, and flexible ureteroscopy, keeping the irrigation pressure and operative time low, and overnight catheter or maybe stentless if possible. So pediatric ureteroscopy is safe and actually is edging towards being done more and more in pediatric patients. Thank you so much.
Thank you very much. It was a really nice talk. Thank you very much. So I said we will keep all the questions for the end, for the next at the end of the session. The next speaker is Professor Gökce from Ankara, and you're a board panelist from the ULIS, and you are going to talk to us about pediatric PCNL, right? So please give us some insights about it, and thank you for your talk.
Thank you, Professor Supina. And first of all, I'd like to thank the ULIS board and the organizers for the invitation. It's a real pleasure for me to be among this great faculty today. And I'll be talking about the pediatric PCNL in the next couple of minutes. I'll try to summarize the recent advancements and where we are in 2021. So related to this topic, I have nothing to disclose. And as an introduction, we should be aware that pediatric nephrolithiasis is a very unique condition. It's not the miniaturized form of adult nephrolithiasis. It's quite different in terms of both medical and surgical management. And in order to establish successful outcomes from endourological procedures, particularly for the PCNL, we need to have a dedicated surgical technique, dedicated instruments, and also some disposables. And if we take a look at the literature, first of all, this review article has been published very recently last year by the EAU Urolithiasis Guidelines panel on the pediatric upper tract lithiasis. And under the section of PNL, the indications were given as the stones greater than 2 centimeters or the ones that are smaller but resistant to shockwave or ureteroscopy. And these indications are more or less the same as in the adult patients. However, in this same article, the stone-free rates were reported to be between 70% to 97%, and the overall complication rates were actually quite high. It was around 20%, and these complication rates were shown to be increased by the multi-track PCNL, the increased tract size, and also the operative times. And this Cochrane review was also published 2 years ago. And although some conclusions were reached and some comparisons were made, actually the main conclusion from this Cochrane review, in my opinion, is that we lack sufficient number of high quality data. For example, we do not have any prospective randomized study comparing the flexible ureteroscopy and percutaneous nephrolithotomy. So we should focus on growing some data. Therefore, we need to look at the multi-center studies and prospective case series. And this CRUISE study has been published almost a decade ago. And at that moment, these stone-free rates were reported to be around 70%. It's quite low. And almost 1 in 10 patients needed a transfusion, and fever and infective complications were observed in around 14% of the patients. And these outcomes actually may not be acceptable in the current era of endourology. And this systematic review and meta-analysis was also published recently, comparing the flexible ureteroscopy and percutaneous nephrolithotomy. And as we can see, the stone-free rates and operative times are almost identical for the 2 treatment options. However, the transfusion rate, hospital stay, and complication rates were all higher in the percutaneous nephrolithotomy group. And this study has been very recently published, comparing the micro PNL and flexible ureteroscopy for stones less than 2 centimeters. And in this study, again, the stone-free rate of the 2 surgical procedures were the same. However, the operative times, fluoroscopy times, lithotripsy times were all shorter in favor of flexible ureteroscopy. Therefore, it's obvious that we need to improve the outcomes of percutaneous nephrolithotomy in the pediatric patients, because if you are drilling a hole in a kidney of a child, then we need to have more favorable outcomes. And in order to do that, we have to improve the stone-free rates while decreasing the complications and diminishing the amount of parenchymal trauma. Also, we need to decrease the duration of operation and hospital stay and improve the quality of life of the child and the family. So in order to do that in our institution with our pediatric urology department, what we do is we're performing mini PNL in supine position with a tubeless fashion. So by performing a procedure with the miniaturized instrumentation, we can decrease the complications and diminish the amount of parenchymal trauma. But we usually avoid doing a micro PNL in order to have the excellent stone-free rates. We do the operation in supine position to decrease the duration of operation, and also we avoid performing a nephrostomy tube in order to decrease the length of hospital stay and also the anxiety of the child. This is the patient positioning. We use the Galdeca modified supine Valdivia position. We elevate the flank region and also put the legs in a modified lithotomy position in order to ease their retrograde access. And how about the tract size in terms of percutaneous nephrolithotomy? It's quite important. Actually, in my opinion, the ideal tract size when you're doing a PCNL in a child is around 14 to 16 French. If you go below 14 French, then the fragment extraction is really hard. If you are doing micro PNL, then it's impossible. Therefore, having around 14 to 16 French sheet is ideal. And going over 18 French is usually unnecessary. It should be actually kept for older children or adolescents with a dilated system and huge stone burden. And if while doing a micro PCNL, we should also be keep in mind that there is risk of increased intrarenal pressure. Therefore, we usually spare it for secondary access during the mini PCNL or only the isolated calyceal stones with less than 10 millimeter diameter, and the stones when the stones are resistant to shockwave lithotripsy. So I'd like to also present a case here. This is a 6-year-old boy presenting with a 27 by 21 millimeter stone located on the right renal pelvis, and there are associated stones of 9 and 7 millimeters. And the Hansfield unit of the stone is quite high, it's around 1600, and the system is quite a little bit dilated. So in this patient, we plan the mini PCNL, put the patient in supine position. And for renal access, we prefer using an ultrasound and fluoroscopy combined access. Using ultrasound really reduces the radiation exposure. And together with that, you can also avoid the concomitant organ injury like bowel injury or kidney or liver or spleen. And following successful puncture, we also use the fluoroscopy for the rest of the procedure. We do a retrograde pyelogram and do the other steps under fluoroscopy guidance. Here we are performing a 15 French one-shot metallic dilation. However, the fascial structures can be very elastic in the pediatric patients, and the kidney may be quite mobile. Therefore, in these cases, performing an 8 or 10 French predilation with a fascial dilator may be an option. And now we're introducing this 16 French metallic sheet over the dilator, and the access is completed. Following that, we introduced the 12 French mini nephroscope. This is the MIP system. And when we reach the stone in the renal pelvis, the next step is, of course, the lithotripsy. And in order to do that, we use the holmium laser in most of the cases. The strategy is fragmentation rather than dusting. We just focus on cutting out 4 or 5 millimeter fragments and take the stone fragments out of the system with the vortex effect, the vacuum cleaner effect. In this effect, we use the basic physics principle, that's the Bernoulli principle, and we just fill the collecting system with some saline, and then we just withdraw the nephroscope out of the sheet, and with the help of the water gradient, the stone fragments follow us, and we do not need any basket or forceps use. Of course, when you do a mini PCNL, one of the major concerns is the elevated intrarenal pressures. However, when you do the operation in supine position, as the direction of the sheet is just parallel to the floor, then the water is evacuated really very fast and easily. Therefore, it also avoids the high intrarenal pressures. And in the procedure, following fragmentation and extraction of the entire stone in the renal pelvis, then we focus on the smaller ones. And again, laser lithotripsy is performed on these stones, and all of the fragments can be taken out of the system very fast and easily. At this step, we also focus on the last stone located in the lower pole. And in this case, instead of fragmenting the stone in the lower pole to avoid torque of the nephroscope, we just flash some saline from the nephroscope, and the stone is dislocated into the renal pelvis and fragmented here. The total duration of the surgery was around 35 minutes. And at the end of the procedure, we just insert a double J stent. In these cases, nowadays, we regularly use a double J stent with a string. Therefore, there's no problem with stent extraction. And at the end of the procedure, we also evaluate the tract under endoscopic vision. And as you can see, there is no significant bleeding. Therefore, no nephrostomy tube was also placed, and the patient was discharged the next morning. So in conclusion, percutaneous nephrolithotomy is the gold standard treatment for complex renal stones in the pediatric population. However, from the literature data, we should be aware that we need to improve the outcomes, we need to improve the stone-free rates, together with that, decrease the complication rates, operative times, and hospital stay. And in order to do that, we need to have some technical improvement in terms of patient positioning, and supine position is a good option. And also we should use ultrasound during our procedure. It should be always readily available in the operating room. Also, as we have now currently available the high power holmium lasers and also the thulium fiber laser, and with the suction systems, I hope we are gonna establish much better outcomes for pediatric percutaneous nephrolithotomy with improved stone-free rates and decreased complications. And I'd like to thank you for your kind attention.
Thank you very much for this really nice talk. Before we go to the quick Q&A sessions, I would like to invite our last speaker, Professor Skolarikos. Professor Skolarikos will talk to us about the less invasive part of the treatment, the medical treatment. Professor Skolarikos comes from Greece, from Athens, and he is a member of the guidelines panel on urolithiasis. So please have the word. We're listening to you. Thank you.
Very much, and thank you for the invitation. I will talk tonight about the medical management of stones in children, which is not favorable as the previous talks, but it's very, very useful, as we all know. I have no conflict of interest, and you know that the prevalence of the stone in children is low, but the recurrence rate is high, actually. And although more than 70% of stones in children contain calcium oxalate stones, every type of stone can be seen in children. And by definition in EAU guidelines, we consider children as a high-risk group and should be treated like that. And when we are, the goals of the treatment, of course, is the complete removal of the stone, but also the prevention of recurrences, the prevention of urinary tract infections, the prevention of renal function, the correction of anatomical problems, and the correction of metabolic problems. And when we talk about high-risk stone formers, and children are high-risk stone formers, then you should, after the basic evaluation, you should perform a specific evaluation. In adults is the 24-hour urine specimens collection, and we will see if these adapt to children in a minute. Regarding medical expulsion therapy in children, in adults, we do have the indication nowadays, and we know that we should use alpha blockers as medical expulsive therapy for distal ureteral stones more than 5 millimeters. In children, though, the experience is very limited. There are 3 randomized controlled trials and 2 retrospective studies saying that it is effective and safe, but you have to realize that as in adults, both in the same is for children, the treatment is off-label. So to start with, first of all, when you operate on a patient, and especially on a child, you should take a fragment for stone analysis. You should, after that, do the basic evaluation. And as I said, because children are considered high-risk stone formers, you should perform a specific metabolic evaluation, and you should treat accordingly to the stone type and the metabolic problem. It is very, very, very difficult to perform 24-hour urine collection for kids, for children. So initially, we are based on the creatinine, on the solute creatinine ratio, the crystal creatinine ratio, I would say, in children. And these are the normal results from a sample, from a spot urine sample. And if these results is abnormal, as I will show you in the algorithms in a minute, then we go to the 24-hour urine collection, and these are the normal values that you should have when you perform 24 urine collection in a kid. And I will explain it in detail in 1 minute. So general preventive measures, like the adult, you have to advise the kid to drink a lot. And actually, in adults, we need a diuresis of 2 to 2.5 liters a day. For kids, the urine output should be more than 1 milliliter per kilogram per body weight. The children should follow a balanced diet. Normal calcium content intake is very, very important for children, but also the limited sodium intake and the limited animal intake is very important. But especially for children, we should be aware of the daily calorie and protein requirements needed. So, for example, in infants and children, for example, if you have a child up to 7 years of age, he needs or she needs 2 to 2.5 grams per kilogram body weight of protein in everyday case. So you have to know and collaborate with a pediatrician or a dietitian, especially for children. To start with now with the algorithm, the kid is coming with a flank pain or symptoms that are not relative initially with a stone, like nausea, vomiting, abdominal pain, or as he may present with hematuria or a passage of a stone. Then we take a detailed medical history, like in every disease, and then we do the basic evaluation, blood and serum and urine analysis. And of course, we perform an ultrasound, which is the initial exam for kids. And KUB and the CT, non-contrast CT scan is not forbidden, but should be very well thought about that before we perform it. Then we do a spot urine sample and we calculate the calcium creatinine level. If it is more than 0.8, 0.6, or 0.2, depending on the age of the kid, then we perform a 24-hour urine examination. If we see that the oxalate to creatinine ratio in spot urine sample is more than 0.3, 0.15, 0.1, depending again on the age of the child, then we perform a 24-hour urine example. Similarly, the citrate to creatinine ratio in spot urine sample, if it is less than 0.05, then we collect urine to detect hypocytraturia. The same goes for cystinuria, the same goes for magnesium, and the same goes for every stone type and the result that we have in the 24-hour urine. So if this is abnormal, then we want to have the first-line therapy, depending on the results of the 24-hour urine collection. Then if it is hypercalciuria and how it is defined, if it is more than 4 milligrams per kilogram per 24 hours in the children, and the child is in hypercalcemic, then you have to exclude increased gastrointestinal absorption and increased calcium resorption from bone conditions. If it is normal calcemic, the child is normal calcemic, then you give potassium citrate 0.5 to 1.5 milliequivalent per kilogram per day. And if you can combine it with hydrochlorothiazide, 1 to 2 milligrams per kilogram per day, if it is of renal origin. If the patient is hyperuricosuric, and hyperuricosuria in children is defined more than 11 milligrams per kilogram per 24 hours up to 5 years of age, and more than 9.3 milligrams per kilogram per 24 hours when the child is more than 5 years, then you can give alkalinization with potassium citrate 0.5 to 1.5 milliequivalent per kilogram per day, or a second-line treatment, allopurinol. I will show you in the next slide. Hyperoxaluria, primary hyperoxaluria, oral oxalobacter formigens, but we need to discuss about this, and pyridoxine, which is the treatment of choice, 25 milligrams per day to 200 milligrams per day. If it is secondary, dietary, then dietary modification and correction of gastrointestinal disorders is the case. If the patient is hypocitric, and citrate means that the child has less than 365 milligrams per 1.73 square meter of 24 hours males, and a little bit lower for female children, for girls, then the treatment is potassium citrate 0.5 to 1.5 milliequivalents per kilogram per day. Hypomagnesuria, we increase the magnesium intake in the diet. And of course, if it is cystinuria, the first line therapy is alkalinization, potassium citrate 0.5 to 1.5 milliequivalents per kilogram per day. The second line treatment for non-calcemic hypercalciuria is the chlorothiazide 10 to 20 milligrams per kilogram per day, hydrochlorothiazide 1 to 2 milligrams per kilogram per day, and amiloride, the potassium preservative antihypertensive medication, 5 milligrams. If it is hyperuricosuria, you can give allopurinol from 4 to 10 milligrams per kilogram per day. If it is hyperoxaluria, again at the same doses, chlorothiazide, hydrochlorothiazide, and amiloride. And cystinuria, you give thiola, 15 milligrams per kilogram per day, depenicillamine, 30 milligrams per kilogram per day, or captopril, 0.5 to 1.5 milligrams per kilogram, and happy to discuss what we recommend in the guidelines. As a third line treatment, normal calcemic hypercalciuria, oral biphosphonate is rarely used nowadays, but you could use it. And hyperoxaluria, of course, for primary hyperoxaluria, the best treatment is, the definitive treatment, not the best, is the liver and kidney transplantation in chronic renal failure. Unfortunately, none of these medications are devoid of complications, or there are specific conditions that you should consider when dealing with these medications. As an example, for alkaline citrate, you all know that the child should monitor, or the parents should monitor the urine pH, and it's not very easy to comply with this. When you use the allopurinol, then you have to adjust the dose if there is renal insufficiency. The calcium intake should be taken 30 minutes before meals. Captopril is, sorry about that, the captopril is a second line option. And of course, the L-methionine is rarely used. This is to acidify urine, rarely used in adults and even in children. Last but not least, thiazides, which is a common medication, especially if there is a renal leak of calcium, then you have to know that there is a risk for agent-induced hypotonic blood pressure, diabetes, hyperuricemia, hypokalemia, followed by intracellular acidosis and hypocitraturia. And for tiopronin, the most important, there are a lot of side effects, but the most important that you should never forget is the risk of tachyphylaxis and proteinuria renal damage. And thank you for your attention.
Thank you for this really nice talk.
Thank you very much.
We're going to open the question sessions, and I think Emanuele wanted to start off with the questions.
The questions are running now at the very end, because everyone was concentrated on listening to the presentations. But I have to say that Sarica had a lot of questions, and the first one is about radiology. And from France, someone asked, what about the right choice, CT scan, IVU, how to measure the infundibule pelvic angle? And another question important is about technique. That is, how many ESWL session do you propose for a patient, and which is the distance between one session and the other, and which is the minimal age of patient you treat by ESWL, and always do you perform the procedure in anesthesia, and which kind of anesthesia or sedation? Professor Sarica?
Yeah, Emmanuel, thank you so much.
So
In order
I
to spare-
recommend you, EVU or CT scan or none of them.
Please.
Intravenous urography or CT scan or none of them.
No. IVU, none. In none of the cases, actually. Very rarely, but I don't remember any. CT scan, we may need in at least a subset of cases in order to identify the stone-related factors, but very limited. In the majority of the cases, we use sonography, and also KUB will be in pediatric cases, let's say, during the follow-up of the cases, of course, helpful for us in order to go further to evaluate the cases from radiologic aspect. Regarding the shockwave sessions,
but I just highlight just one thing, what you said. I think for the audience, it's here really important to know, to highlight what you just said, that IVU in pediatric stones and in pediatric urology in general has no more place. I think it's a really important take-home message.
Exactly.
In the adult too, of course.
Exactly.
The other question is just how many ESWL are allowed in a child, and if you perform more than one session, which is the distance between one session and the other, and then which is the power, the maximal power you use in the ESWL treatment?
Nice questions again. Regarding the number of sessions, as I presented in my...
And the timing of sessions.
Exactly. When it comes to the management of stones in children, if we choose the size of the stone very well, that means stone sizing less than 1.5 centimeter, at least in my practice, it's very, very effective. And in the majority of the cases, one session is really enough. If we need, we may have a second session, but it will be really rare in a limited number of cases. And the time period between two sessions will be again at least a week or 10 days when compared with the adults, because the kidney of the children is growing and it's very sensitive, and we need to take care. A week or at least 10 days for kidney stones, not for ureteric stones, of course.
This is a question, just personal one. If you don't perform any CT scan, you don't take care about the Hounsfield units. So you don't think that is important to know something about the stone composition or the stone hardness?
No, Emmanuel, I talked about the follow-up, but prior to the procedure, we may need, in a certain percent of the cases, to evaluate the stone size, stone-related factors, and also the hardness of stone to get an idea about Hounsfield unit. Okay. I talked about the follow-up. During follow-up, radiation should be less, and CT will be needed really less. The number, we need to spare time for other speakers also. Number of shock waves, no more than 1,500, and the level of energy, no more than 30 joules. For example, I'm working with Delta 3, a nice system, excellent system, and its levels is from level 3, right? Antibiotic prophylaxis, it's not a must. It's not a must in all cases.
Perhaps Françoise has some questions for Somani.
Well, yes, I think there were a lot of questions for you, Bhaskar, about access sheet. So could you tell us more about the use of access sheets in pediatric urology? I'm also curious.
So the first thing I'll say is, in pediatric, there's a general principle, smaller is better, like with any endoscopic surgery. So the first thing, access sheet is not always necessary. The second thing, when you're treating infected stones or large stones, if you do have to use an access sheet, I always map it. So I'll do a semi-rigid ureteroscopy first. If the semi-rigid ureteroscopy shows it's a compliant ureter and the access sheet will go, I will use the smallest possible. For me, it's 9.5, 11.5. Then I'll use an access sheet, but it is not for every stone. It is not for every case. But there are certain situations where they're helpful. So use the smallest access sheet if possible. Map the ureter first with the semi-rigid ureteroscopy so you're not causing any trauma. And if you're careful, then I think it's a good tool, especially when you're doing large stones, because there's a lot of stone dust and you want the vision to be good, the irrigation pressure to be okay. So we have now done almost 30 cases with access sheet, and with Anna Bijons from Spain, we have jointly combined our data, and of 70 or 65 patients, we had one minor injury. There was no other major or long-term complications. So that shows the use of access sheet in specialist hands, when indicated in a safe practice, is actually very, very good.
That's really interesting. So you said it, the smaller is the better, but does it mean you have a cutoff limit, a cutoff age where it's not possible to use an access sheet or to do a minimally invasive surgery and you have to open it?
So that's a very good question. So in my 10 years of doing pediatric ureteroscopy practice, we have never done open surgery. If the access sheet, so under 6 years of age, we generally try and not use it commonly unless they're pre-stented. So I think pre-stenting, as a general rule, we don't pre-stent patients. But if they are less than, especially 3 years old, I don't think you should, because the telescope will go. And then with modern day lasers, because you can do high frequency, etc., you don't always need to use an access sheet. But if you're struggling, then I would say if you can't get it, just railroad the flexible scope. If that doesn't go, stent and come back. That is the safest possible rule. In terms of open surgery, I mean, if ureteroscopy doesn't work, you always have the option of PCNL. Now, in our setup, we have been doing ureteroscopy for a long time, but I showed in my talk, one of the papers, there was a center who specialized in mini PCNL. Our center specialized in ureteroscopy, and the outcomes are similar. So I'm not going to say one is better than the other. Then it comes down to your experience, your center's experience, and what you're comfortable with, taking the patient parents into confidence. So you must make sure it's a shared decision making with them. Give them the option, because sometimes you might have to say you might need 2 procedures if you do ureteroscopy. But it has to be balanced out. But open surgery, I have to say, in my practice, we haven't done it. I'm not going to say that people, can't defend doing it. Again, especially in pediatric, I think open surgery might have a role, but not in my practice.
Mm-hmm. Okay. So I think we have some questions for Gökce, Dr. Gökce. Can you listen to me? Yeah.
Yes.
Oh, thank you. There are 3 questions important. The first one is multiple accesses or bigger access in bigger stones. The second one is just about hypothermia in PCNL that is a problem perhaps in a child. And the third one is about the puncture, of course. Do you puncture always, even in the baby, through the calyx to get the pelvis, or do you perform just a direct puncture?
Okay, so to start with the question about the staghorn stones, actually, I usually, again, prefer just 16 French for the staghorn stones as well. The reason is that, and also for the puncture, I prefer to do a transpapillary calyceal puncture, not direct onto the pelvis. But in the pediatric population, for staghorn stones, what I prefer is a middle pole puncture. When you do a middle pole puncture, then you can navigate the lower pole and upper pole really very easily with a miniaturized instrumentation, of course. And the compliance of that calyx is really very low. Therefore, going over 16 French, you're going to disrupt that calyx, and you will have long-term consequences. You will lose more nephrons, and as it's a child, there's a long life ahead. So I still prefer doing 16 French for the staghorns. And if we need a secondary puncture, And then I prefer doing ultra mini for the secondary puncture, like an 11 French. And I just fragment the stone with the laser and wash it into the renal pelvis from an upper pole, for example, and take the stone fragments out from our main 16 French sheet. It's the best case. And also ECIRS may be an option for children as well, but of course you have the problem with the ureteral compliance to insert the flexible ureteroscope. But when possible, instead of doing a secondary puncture, doing ECIRS is a better option. And for staghorn stones,
about hypothermia,
Yeah,
are you afraid about, and what do you do if you are afraid?
Yeah, I'm really very concerned about hypothermia. Compared to adults, it's a much bigger problem with the pediatric population. And two things are really necessary to prevent it. First of all, you need to preheat your irrigation fluids to around 37 degrees that we prefer. And the second one is you need to drape your patient very well. The main problem with hypothermia is some irrigation fluid may leak beneath your drape, just behind the patient into the operating table, and it causes the hypothermia. So you need to drape your patient well. We usually just tear the drape while doing an ultrasound guided puncture to get a better read in the ultrasound. So when you do it, please make sure that no irrigation fluid leaks behind the patient into the operating table, and just by preheating, it will be okay, and you will not have any complications related to hypothermia. These are the two important things.
Thank you. Francois? Francois? No, something wrong.
Screen is frozen, I think.
The screen is frozen, yeah. So we have some...
Yeah.
Francois, it's just your turn.
Sorry.
Skolarikos.
Yes, we had a question from the audience about what your preferred medication would be for medical expulsive therapy in young boys. What would you use and at what dosage?
Well, the correct answer to me is no med for anyone, no med for children. But there is evidence, as I said, that you can use it. And you can use alpha blocker, you can use calcium channel inhibitors. The most commonly used is tamsulosin, just because of the good profile, 0.4 milligrams. And I mean, if you see a systematic review back to 2015, which is the only one for the 3 randomized controlled trials, you will see that the result is independent to age, but I wouldn't use it to children less than 7 years old. That's a personal opinion, though.
Okay, thank you. There are still questions coming up from the audience. I don't know if you have more questions, Emmanuel. I'm looking.
No, I think that we are perfect
Yeah.
at time, and so
Exactly. We have to wrap up, I think.
Unfortunately, we have to stop this charming session. Really, I have to read rapidly in the question and answer section that everyone seems to be very satisfied with the presentation. And so I have to thank very much the presenters, really, and my co-chairman too.
Thank you indeed. I think indeed when I see all the questions, there's time for another webinar, so it will happen another time. And I think we have to thank all the speakers for those really nice presentations. And it was a pleasure to chair this session with you, Emmanuel.
Thank you very much. Thank you.
Thank you so much, everyone. Very enjoyable, and again, a learning experience for us as well.
Thank you so much, Emmanuel and Francois. Thanks, dear friends. On the name of ULIS, thank you so much.